So I would like to introduce you to Dr. Sherwin Hua. Dr. Hua finished his undergrad and medical education at Northwestern, the 7-year program, the honors program in medical education. He also completed 5 years to get his PhD in neural network modeling, focusing on brain development, learning, and motor control. And after 12 years at Northwestern, he moved to Johns Hopkins Hospital to do his neurosurgical residency. After graduating from Hopkins, Dr. Hua moved to Los Angeles to join a private practice group that was affiliated with USC, University of Southern California. At this time, this is where he developed his quest to develop the most minimally invasive technique in spine surgery. And after 7 years in LA and nearly completed the development of his minimally invasive technique, Dr. Hua moved to the Bay Area. And now we're lucky to have him as one of our colleagues in the area, bringing his world-class expertise in minimally invasive spine surgery to the local community. Dr. Hua has over 40 publications and several patents on minimally invasive spine and brain surgery. Please welcome Dr. Sherwin Hua.
Thank you. It's a pleasure to be here today. Today I'm going to talk about spine, back, pain, and surgery. It's one of the passions I've been working on for the last 10 years. When I moved up here about 2 years ago, when I met Hui Win, about a year ago, I found out that what he was working on and developed in terms of a single incision, single site, abdominal laparoscopic robotic surgery, it was pretty much exactly what I've been trying to do for spine surgery in the last 10 years. And so I just wanted to kind of talk about how it applies to spine surgery, what's possible, what holds in the future. The first thing is, in terms of spine problems and spine surgery, it is a very big problem. This is a big long list. The only thing you need to know is, in terms of diagnosis, hospital costs, in terms of spine problems, it's number 6 in terms of all the diagnosis that's seen in the hospital. That's just one less than heart attack and childbirth. And if you look at COPD and diabetes, add these together, the cost of taking care of COPD and diabetes equals spinal problems. So it's a huge problem. In terms of surgical procedures, spinal fusion is number 1 in terms of costing the healthcare system in a year. This actually, I didn't even know this until I started looking into it. When you take into account all the procedures done in the hospital, including intubation, mechanical ventilation, blood draws, spinal fusion is number 2. The second most costly procedure done in the United States in the hospital. So not only is spinal problems and spinal fusion costly and huge, it's also the biggest growing problem or cost. As you see here, it's at the very top. It's a growth rate of the cost of spinal fusion is 10 to 14% a year. And this is why insurance companies, Medicare, Obamacare, and Obama are very concerned about spinal fusion and spinal problems because it costs a lot. So if you think about anything that could make spinal fusion and spinal problems a little more efficient, better for the patient, it could make a big difference on the healthcare system. On the other side of this, we know what insurance companies want. They want to lower the cost. But what do patients want out of spinal surgery? Patients want the latest technology. They want something that they can just go to a hospital, get something zap like a laser, and then they're all better. Well, right now there's nothing like that. But some of the stuff that is out there that patients always ask about is Laser Spine Institute, robotics, laparoscopic surgery. I think those are still a little ways ahead of us in terms of spine surgery, but we're starting to work on them. But what I want to develop is something where we can get one of the most difficult procedures and the longest, most costly again, spinal fusion, and make it more efficient and better for the patient. I just want to show you this video of what is a spinal fusion. Spinal fusion really has two parts. One is to remove the disc that separates between two vertebrae and then replace it with the implant that keeps the disc apart and causes the bones to grow together. That's the first part. Second part is to put 4 screws in the back and lock the two bones together. And if you have these two parts, the bones will grow and fuse together. And here you see the screws going in. So typical surgery for spinal fusion is 4 to 6 inches. The patients may last in the hospital 7 days, sometimes 4 to 7 days in the hospital. And there's significant pain. And also the bigger incision, the higher risk of infection and complications. Companies like Medtronic has come up with a minimally invasive procedure. Minimally invasive meaning the incisions are smaller. But Medtronic, the system is called the sextant. It's called sextant because there are 6 incisions involved. So even though the incisions are small, there's 6 incisions. And actually for a 2 level, it's 8 incisions. And you can see in this picture, this is a patient that my previous partner operated on he's actually a very experienced minimally invasive spine surgeon in LA. In this patient, he had a single level spine surgery. There's 6 incisions. Each one is at least the size of a dime. So one of the reasons why I wanted to make spine surgery smaller incision is because if you add all these incisions up, it's going to be longer than a regular open incision. So to me, this is not minimal. This is not minimally invasive. What I want to do is to have this surgery performed through a single incision. So similar to the single site robotic surgery that we developed. So a single incision. This actually is a full lumbar fusion through a single dime-sized incision. There's no shortcuts here. It's 4 screws, a big implant, everything decompressed. And I'll show you how it's possible, and it's not actually that hard. It's just people haven't thought about it. Compared to the sextant, it's an 83% reduction in incision size. The reason why we can do this in the lumbar spine is because the lumbar spine is curved in a way, kind of like a wheel, where if you had a single point at the skin, it's almost like spokes on a wheel. You can access multiple bones and vertebrae through a single point. And because of this allows us to put screws in a tiny incision. The screws, luckily, are also favorable because screws and implants are skinny and long, so they all fit through a small incision. As you can see here, one hole, you can angle the trajectory, and you can fit multiple screws. So this is not a problem. The next step after this is what about the implant you put in the disc space? Those are quite big, and the bigger is better. Sometimes we put them in the front, called an A-lift. Sometimes we put them in the side, called an X-lift. Well, it turns out in the last 2-3 years, companies have come out with expandable implants. Some expand kind of like a car jack on the left here. Some expand like a balloon. And this one that I use quite a bit curves around. So it's very long and curves around into a fairly big implant. And so now that we have the technology to put a big implant through a small incision, as well as putting multiple screws in a single small hole. So what results can we get? So I'll just show you a couple of examples real quick. So this patient has a lot of back pain and leg pain. You can see here that the spine is shifted. It's not aligned. And because of that, there's a lot of pinching stenosis, narrowing of the nerves. And so she has both back pain and leg pain. This condition, spondylolisthesis, you have to have a fusion. There's no other way. So this patient, I clean out the disc space, put a big spacer in, put 4 screws, and also reduce the slippage through 2 small incisions. This is a time earlier when I used 2 small incisions instead of 1. Both of them are smaller than the size of a dime. She did very well. Nowadays, I'm able to do the same thing but through a single small incision. 4 screws, a big implant. Actually, these are 2 implants here. Through a single incision the size of a dime. So here we show it's possible. The single incision spine fusion, small incision, is possible. Here is a patient that previously had a microdiscectomy by a pretty well-known surgeon in LA. The microdiscectomy is just shaving the disc that popped out. No implant or anything. This incision is about the size of an inch. A couple years later, his disc progressed and degenerated even more. At this point, he had back pain and leg pain. He needed a fusion. So I went in and did a full fusion, no shortcuts again, 4 screws, inner body. I went through half the incision of what he did a microdiscectomy. This patient went home the next day, and after 2 months, he went to Alaska for a camping trip with his family. So it's definitely possible. So this procedure is the most minimally invasive spine fusion available. There are other things that come up, but they're not as small and they take shortcuts. This takes no shortcuts. It's faster recovery and avoids a laminectomy. The reason why laminectomy is important is because the lamina allows muscles to attach to it. When you have a laminectomy, you make things unstable. I'll talk about this in a little while. Smaller incision means lower infection rates. Patients recover faster. Some of the patients at 60 or 70 years old who undergo this, they can walk a mile to a mile and a half after 2 weeks. This normally takes 4 to 6 weeks to happen. Fewer complications, faster recovery rates, shorter hospital stays. That's going to decrease hospital costs. And as we talked about this before, this is very costly to the healthcare system in the United States. And thus, it may be important for healthcare in general. Next, I'm going to change pace a little bit. What happens if a patient cannot have a spinal fusion? Say a patient is older, he can't undergo general anesthesia. A patient has an MRI that doesn't show anything, or it shows that there's just everything is everywhere, and it just can't fuse every single bone. Well, the alternative to spinal fusion is called spinal cord stimulation. Spinal cord stimulation is a procedure where you implant a device kind of like a pacemaker, except the pacemaker has about 32 channels in this case, and electrodes are placed over the spinal cord. And once it's placed over the spinal cord, the pain signals that are traveling from the leg, from the arm, from the shoulders, up through the spinal cord, they are intercepted by this device. And when it passes a current, it scrambles it. It turns the pain into a numbing sensation, into a buzzing. Most patients feel that it is much better. The good thing about this procedure, several good things. That it's local anesthetic, no general, it's outpatient. And there's 2 parts to it. One is a trial. So first, you get to test drive it. You get to take it home and test to see if you like it or not. So this is an outpatient procedure. You just place 1 electrode or 2 electrodes in, it comes out the back, and you get to plug it in and take it home and see if you like it. And after that 1-week period, you know if it's going to work or not. If it doesn't, then you just pull it out. But if it does, then you go on to the full implant. The full implant can be either a paddle like this, or what I prefer is just 2 little wires, because they just go right up. And you can see how the electrodes, when they turn on, you can combine them with different combinations of electrodes, up to 32 electrodes. And then you can precisely pinpoint where you want to stimulate and which signals you want to jam on the spinal cord. And then you can control what the numbing sensation, where it's going to be. This is excellent for both the lower back and the lumbar. One of the biggest problems people have when they get this procedure is people who had previous surgery and the pain still persists. And it's a very common problem. It's called failed back surgery syndrome or post-laminectomy syndrome. Post-laminectomy syndrome is actually an ICD-9 name, it's code. It's actually an ICD-9 code. You can see here by adjusting where the stimulation, what electrodes are on, you can change what pattern is covering what, where in the skin. So again, the benefits are, you have this first stage where you test it, you test drive it. Second, you avoid general anesthesia. Patients are actually awake during surgery. We actually talk to them when we insert this, and when we stimulate, they tell us exactly what the stimulation is. Thus, on the table, you know that you got exactly where they need the pain. No other surgeries like this. Every other surgery, you're waiting for them to wake up so you can ask them, is it better, is it better? Here, you know exactly that they got the stimulation exactly where they need it. And it's safe through intravenous general anesthesia. These are outpatient procedures. It's continuously adjustable. So if your pain shifts to the other side, if your back pain becomes more than your leg pain, you can adjust that. You have different programs. And also, it's not just for pain. Actually, in Europe, the bigger indication for this is actually for vascular claudication in the legs, and also for persistent angina. You can treat the angina. For some reason, stimulating the nerves also open the blood vessel. We don't understand exactly why, but it's very reproducible. So there's a lot more to learn about this technology. So basically, that's all the talk. But here are a couple of takeaway points. First of all, when you're a hammer, everything looks like a nail. How this applies to surgeons is that if you're a surgeon, every patient gets referred to you, you're going to want to operate on it, because that's all you do. And you operate, until the patient says, no, don't operate on that, and it's not better. And then you refer them to pain management. Pain management, all they do is injections, they go injection, and eventually release some stimulation. You can have somebody who understands both sides. So I've had patients who get referred to me for surgery, and I said, no. Fusion is not going to help you. A better way is spinal stimulation. Whereas some people get referred to me even by surgeons for spinal stimulation when they had surgery and it didn't work. I said, no, this level of pain, spinal stimulation will never work. If you have something in there, you need surgery. I'd operate on it before. It's got better. So you can have people more of a comprehensive approach. That's always better for the patient. The second thing is, like Quiglin's philosophy, less is more. First of all, you have to be effective. You have to treat the pain. If you can treat the pain with less surgery, more conservative approach, smaller incision, less complications, it's always better. And in that same vein, avoid laminectomy. I talked to you about post-laminectomy syndrome. Removing the bone. You don't need to do it. I realized this 6-7 years ago. I stopped doing laminectomies. For the neck, I don't do laminectomies. I open the lamina up called abdominoplasty. It works very well. It's done outside the United States much more commonly, just because in the United States it doesn't pay very well. Also in the lower back, I stopped doing laminectomies because all you need is a little window. You save the structure of the bone. Last thing is, you have to give the patients what they want. Sometimes in the past, the surgeons always dictate whatever the patients, the patients come in and say, you need surgery, that's it. But nowadays, surgeons, they can go anywhere, as long as their insurance plans allow it. They can have second opinions, third opinions, four opinions. And for UCSF, so you have to understand what they want. They want minimally invasive, they want to leave the hospital soon, they want good results. And you can sit down and explain to them, and they will trust you with your life. And it's always an honor to do that. But it's hard work. And that's basically my talk. The last one, I just want to thank the sponsors. Boston Scientific, which is one of the three big companies for spine core stimulation. I work with all of them. I think Boston Scientific technology is probably the best in back pain. Nestle is one of the main spine companies that I use. Also, we recently had some nice toys in the operating room at Regional Hospital. This Aero intraoperative CT scanner, as well as the brain lab. There are actually only 10 of these units out in the United States. This is the only unit in Northern California. And so we can then place brain tumors. We have the ability to see inside the operating room. We can have a complete discussion of brain tumors. So with this technology, we really have pushed our ability to help the patient while they're still in the operating room. Thank you.
Thank you so much, Dr. Hua. And we actually have a few minutes for questions. If you have any questions for Dr. Sherwin Hua.
Yes.
Do you see this technique applied in surgical oncology for, say, spine meds?
Absolutely, absolutely. Actually, brain tumors, one of the biggest problems is you don't know where the tumor starts and where the tumor ends sometimes, especially when it gets close to very important parts of the brain. So here you can do CT scan, and you can see where the end is. So it's much more helpful. And spine meds, when you reconstruct, it definitely is helpful. It's very helpful. Very good.
What's the length of stay for typical patients?
Yeah, so length of stay for the regular surgery for spinal fusion probably is between 4 to 7 days. For the small incision, it depends on the age. So if it's a younger patient, it could be the same day probably. You have to compare them. But 1, 2, sometimes 3 days. The other thing is, what I found that when you have a regular open surgery, the day after, when you walk into the room, the patient's like frozen. They're like gritting their jaw, pinching their jaw. It's this unbearable pain. But then in the smallest and minimally invasive, the giant spine surgery, you walk in and you ask, oh, how's your pain? They go, yeah, there's a lot of pain. But they're walking to the bathroom. They go, oh, yeah, it hurts. But they're walking around, they're bleeding. So when you ask one person how the pain is, they're going to say it's painful because they just had even a small surgery is painful. But the overall recovery, say at 2 weeks, is huge.
Well, thank you so much, Dr. Sherwin Hua. Fantastic talk.